Welcome back to American Medicine Today. I'm Kimberly Bonati alongside Dr. Bonati, and we'll be discussing conscious IV sedation. Doc, why is that such an important feature of the Bonati spine procedures?
When I started my practice in orthopedic surgery, initially I did fractures and backs, and in the process doing backs, I did open surgery. Every time that I did open surgery, one of the major concerns was the time that we invest taking the patient under an anesthetic.
Mm-hmm.
Not only the complications that can happen post-operative time, that is usually that elimination of the anesthetic through the liver, create some types of some abnormalities in older people.
Right.
So the concern about the treatment was not only associated with the difficulty of the surgery,
Mm-hmm.
the time that consumed this patient under anesthesia, and the recovery of this patient post-surgery. And to eliminate that, some of the problems, we eliminate the ones that I believe they were the ones that impede the patients to be treated.
All right.
For example, there were people that they have some liver problems,
Mm-hmm.
people that they have heart problems, and the anesthesiologists always fought about these patients shouldn't have surgery. Then those patients were practically put in the back line of treatment because they were not good candidates to have the surgery, but at the same time, this patient had so much pain that we need to do some solutions. And then they were treated in different ways that they were not really successful.
Okay.
So,
And that's due to general anesthesia. That's why they weren't good candidates.
exactly.
Okay.
I start to think, how about if we treat these patients in a different way?
Mm-hmm.
And that's when I start to see we need to minimize the incision. We need to minimize the damage to the bones, to the ligaments, and to the muscles,
Right.
so we can create an access to the area, operate these patients without really the roadblocks of general anesthesia. That was an initial part how I developed those tubes
Mm-hmm.
to do a surgical procedure using an arthroscope and using the tubes to arrive directly to the area where the problem was located.
All right.
But when I did that, we're still being using general anesthesia.
Mm-hmm.
Well, I thought that if we block the skin and then we block the fascia, probably we can put the tubes inside without creating pain.
Anesthetize those areas?
Yes, use some
Okay.
anesthetic in that areas like xylocaine,
Sure.
a minimal amount, maybe around 5 cc's or
Right.
something like that.
Okay.
When we did that, I realized that cutting the skin was not a problem because it was numb.
Right.
Numbing the fascia remove a lot of discomfort because the fascia is very sensitive.
Right.
So when we numb those areas, we were able to put the tubes to the area that we need to operate. But at that time, also we have another important element, the bones. And when we touch the bones, that was pain.
All right.
So the problem was, well, we need to numb the periosteum in this area. So we put some very small injections on the periosteum, and we found that, to our surprise, that we can do surgery where we can use the instrumentation and the patient is not going to have pain.
Right.
But the beauty of this is not only he's not going to have pain, but also he will be able to talk to us, will communicate with us.
Mm-hmm.
And with that type, we combine some sedation so the patient will not be with some fear, thinking, I'm going to hurt.
Right.
And that is a drawback.
So they're slightly sedated, but they're able to communicate through the entire procedure with not only you, but the rest of the surgical staff.
Yeah. by the 90s, we're already thinking in that's how we are going to treat this.
Right. So for more than 30 years, you've been doing that. And what's really weird is nowadays you see people promoting the fact that they're the first doing conscious sedation and they're a new company.
After 80,000 procedures performed,
Right.
a lot of this one was just think in the medical society that is a way to do it. And today, different specialties start to test that technique. Now, let me tell you this is not something that was so easy.
Correct.
Because I was fiercely attacked, thinking that was practically not hard on myself to treat a patient in that way because the horrendous pain that patient may have.
Right.
Today, we know that those patients, they never hurt. Now, there are sometimes situations where patients are scared. And when you do that, you sedate them a little bit, and the patient responds normal.
But they can still feel if you're at the root cause of their pain. And that interaction during your surgery is what brings about the incredible results because you said, is this your pain? And they're able to locate it. Yes, this is it. And then you go and you take away the impingement, you make more room for the nerve, and suddenly they go, pain is gone.
The patient becomes the owner of the body is telling you what you are doing.
Right.
And if what you are doing is helping or not.
Mm-hmm. And not only that, they're able to watch and they go, oh, that's what was causing me that agonizing pain. Yet if they were put under general anesthesia, they would never know.
Usually the general anesthesia still is necessary when you need to do procedures like open surgery.
Sure.
In the spine. And unfortunately, people continue doing fusions. And you know my feelings about fusion.
I
Not
do.
only I don't think they don't work, I think they are a situation where the recovery for the patient takes too long.
It does.
So you don't never know if the surgery worked for you or not because you are in so much pain for so long that you expect that this is part of the treatment. And the real truth is with our procedure, the patient is walking 1 hour after the surgery.
Right. And we'll talk more about those procedures and the incredible 98.75% patient-reported satisfaction in another episode. Thank you for watching American Medicine Today. You can check us out anytime, anywhere if you search AMT on all your streaming platforms.